Okay, so thank you everybody for coming to this about one of our clinical cognitive neuropsychology Zoom seminars. They're run from Chulalongkorn University in Bangkok, and I know most of you are Thai, but we do have people from all over the world attending tonight. It should be a very interesting presentation, and we also have a very sort of mixed crowd. I've checked, we've got about people from about 10 different countries attending. So I'm very pleased tonight that we have a very special guest, Dr. Ashok Jansari. Now, Ashok is working with us at Chulalongkorn University on some research on executive functions. So we're very pleased to have him here tonight. Now, Ashok has a degree in experimental psychology from King's College, Cambridge. And following that, he did a doctorate in neuropsychology at the University of Sussex. And he's conducted postdoctoral work with Antonio Damasio at the University of Iowa, and he's won several awards for his research and for his teaching. So it's very, it's great for us tonight to have this major neuropsychologist presenting for us on some of his latest research. So I'll hand it over to Ashok. Tell us your presentation.
Thank you very much. Thank you, Graham, and my other hosts in Bangkok for inviting me. It's quite a pleasure to be invited, and I hope that I give you something interesting to listen to. So I'm going to share my screen, and okay, I'm just going to close the window near me just to reduce the sound. So if you just one moment. Sorry about that. So I just want to check that this is now being seen properly, just in proper mode. Is that okay?
Yes.
Okay, great. So shall I begin?
Yes, go ahead.
Yep.
Okay, again, thank you very much for this invitation, and I hope that you find the next 45 minutes or so of my talk interesting. So I've given my talk this title, Detecting Preclinical Signs of Mild Cognitive Impairment or Dementia in Healthy Elderly Populations. And it's about a new paradigm that myself and my team have created. So I like to get the thanks out of the way to begin with, just to make sure that it's obvious that I didn't do this on my own. It's thanks to this amazing PhD student of mine, Terry McGibbon, who is the center of all of this work, and then a range of master's students and a research assistant who've helped me over time. And this list is growing because this is becoming a bigger and bigger research project. So as an overview, I'm going to give you a general background to memory and an introduction to this term, accelerated long-term forgetting, or ALF, which some of you may have heard of, but many won't have. Then I'll tell you about the first experiment, which is a detailed case study that I did on a patient with this condition, and then how we moved from that detailed case study to developing possibly a new clinical measure. Then I'll show how we moved from working with this clinical patient to working with healthy aging. And this is one of those lovely accidents in research where we just tried out this measure that we'd created on a healthy aging population and found what we think might be a preclinical sign of dementia. And then finally in experiment 4, I'm going to show you how we replicated that and tried to compare the results to a standardized test of memory. So taking a trip down memory lane, generally we think of a distinction between short-term memory and long-term memory. And this is supported by evidence from both healthy controls and patients with amnesia who can't hold anything for more than about 2 minutes. So anything that happened more than 2 minutes ago, patients with very classical amnesia cannot hold on to that, so because their ability to transfer information to long-term memory has been compromised. And theoretically, this has resulted in famous models like the modal or multi-store model by Atkinson and Schifrin. And these suggested that once information is being transferred from short-term to long-term memory, the trace is very durable and can last up to a lifetime. Now, that is the basis for these older models, but what we've been finding in the last few decades is that with older people, this is not necessarily the case. Now, the problem with this transfer of information from anamnesics can be detected with patients who are severe cases who can't hold information from 1 minute to the next. So I'm going to show you a video of me working with one of my former patients, Nicola. And in this test, in this video, I just do an informal test with her where I present 8 words to her and ask her to recall them straight away, which is what short-term memory does. Then I speak to her for about 45 seconds and ask her again whether she can remember those words, because by that point, the information should have moved into long-term memory. So let's see what happens.
Okay, I'm just going to read out 8 words to you, and what I'd like you to do is to just, when I've finished, repeat or whatever you can. Okay, so are you ready? Okay. Table, lion, apple, shoe, carpet, robin, carrot, flower.
Table, apple, lion, shoe, flower. Can't remember anymore.
You did pretty well there. You got 5 out of 8. So.
I got about 4.
Well, you did better than Reg there, so well done. Okay, how are you at recognising people on TV? Do you watch much TV or films?
I watch television, don't I? And films.
Mm-hmm.
Do you recognise the people on the film?
I don't know, do I?
Sometimes.
Sometimes.
What's your favourite programme?
EastEnders, I suppose. If we have it on.
So what's happening in EastEnders at the moment?
I couldn't tell you.
Okay.
I'd have to wait for it to start and then
It comes back.
I think, oh, so.
Okay. I'm just going to go back to those words that I gave you. Can you tell me what words I gave you?
No, I can't.
You remember one of them?
No.
Okay, now I'm just going to see how well the couch over there does. Okay.
Apple, lion, robin.
Robin, table.
I've got 4, you see.
That was 4 again, yeah.
4, yeah.
That was between 2 of you there.
Yeah,
Right,
2,
yes,
yeah.
right.
Okay.
I've got 2, that's right. Yeah.
Now, if you don't mind, I'm just going to go to the bathroom. It's
Right.
just near
Just
the door,
round by
isn't
the
it?
front door, yeah.
Okay. If you guys just want to talk about what you did in Spain.
What we do is
Yeah. Tell Nicola about what you guys got up to in Spain.
You remember going to Spain? Yeah, and you got back on
No, I don't remember
Thursday.
going.
Tuesday night we
Tuesday.
do that.
Hello, everybody.
Hello.
Hi, Ash.
Hello. Have we met before?
I don't think so.
No. My name's Ash.
And I'm Nicola.
So what you see there is a very, very classic sign of dementia, of amnesia, where Nicola's short-term memory is completely intact. So she's able to hold on to 5 of those 8 words without any problems. But literally a minute later, after I've been talking to her about TV, etc., she can't remember a single word, while her husband and sister can still remember about 4 words. And when I go out of the room and come back in 2 minutes later, she doesn't know who I am. So that's very classical amnesia. It's a very severe form, so not all patients are as bad as this, but it shows you how bad it can be. Now, clinically, tests such as the Wechsler memory scale, logical memory scale, can be used where an individual is told a story which involves a certain amount of information, and there's about 20 points that you can get for the information from that story. And you can test people immediately afterwards, just like I did with Nicola, and then typically at a delayed point half an hour later. And this is data from 2 patients, KJ and DB, that were tested by, I think, Alan Badley and Barbara Wilson in the UK. And what you see is a typical pattern like you'd find with Nicola, where at the immediate time point, there's no problems in recalling information, but half an hour later, the information is gone. So that's classical memory. So what is this thing called accelerated long-term forgetting, or the long-term amnesia, which is the type of disorder that I'm talking about? It was first coined by Narendra Kapoor, and then subsequently a number of other studies have been done which have replicated this either in groups or in individual cases. And typically a patient...
Ashok?
Yes?
Sorry, your sound is going off. It's like going quiet occasionally. Is it, is there a way of... I don't, it's just sort of coming and going a little. Is it possible to, I don't know, maybe speak closer to the microphone, or I don't know what...
I'm going to attach an external, oh no, I don't have an external mic. I don't know what's causing that. Oh, is that still happening?
Yes.
Oh, shoot. This has happened before. I'm not sure what the cause of it is. And I don't have an external microphone, unfortunately. Let me see if I can try something. Oh, I can't even do that.
It's, we can hear you. It's just sort of...
Is it better now?
Yes.
Okay, so I'll try to sit as close as possible. I wonder whether the sound that's coming in from people coming to the waiting room is muting me for a moment.
Possibly.
But I'll try to sit as close to the microphone as possible. Okay. And I hope that corrects the issue. And I'm sorry about this. If it happens again, do tell me. So patients complain of profound memory problems, but they pass the standard clinical tests like the one that I've just shown you. So to a clinician, they show no signs of memory problems, even though subjectively they're complaining of memory problems. And all of these patients tend to have epileptic involvement, certainly in the cases that were studied before. And they all show marked anterograde memory problems in learning new information, but a variety of retrograde memory problems. So that's differences in memory for things that happened before the epilepsy started up. So what we have here is a conundrum with these patients who are saying that they've got memory problems, but they passed the clinical tests. So what's going on? And Narendra Kapoor coined this term long-term amnesia because he felt that the issue wasn't about a problem in moving information from short-term to long-term memory, the way that we find in classical amnesics, but in terms of an amnesia within long-term memory, once it's actually arrived in long-term memory. And then this term accelerated long-term forgetting is effectively saying that we all forget, and forgetting is a completely natural phenomenon. But what's happening in these patients is that they're showing a very accelerated form of it to amnesic levels. So this is what the area that I started working in when I met this patient who was actually the stepfather of a student of mine. And at the time, he was about 65 years old. And a few years before that, he'd started noticing memory problems. And he experienced periods of awareness going for a few seconds, which probably were absent seizures. And these would usually happen every 4 weeks or so after he'd been quite tired and had a bad night's sleep. His wife reported that his memories faded within 4 to 6 weeks of an event happening. Now, the patient and his wife went around the world for their 25th wedding anniversary, and a few months later, he couldn't even remember having been to Hawaii. So it wasn't a small piece of forgetting, like where his keys were, but a major piece of autobiographical memory forgetting. But scans showed that there were no obvious lesions, and I'll show you that in a moment, and tests didn't reveal any sign of Alzheimer's or any of the other dementias. After study 1, however, we did do sleep deprivation telemetry, and we did find right temporal lobe epilepsy. So just in terms of scans, this is a cross-section of the patient's brain. And by comparison, this is Nicola, who you saw in the video. And what you see here is in the medial temporal lobe area, a lot of damage caused by the herpes simplex encephalitis that she'd suffered from. But in this patient, those same structures look virtually intact, or intact to even radiologists who looked at them. So what we have is a conundrum of a patient who's complaining of memory problems, passes the standard memory test, and doesn't show any gross signs of brain damage. On clinical testing, I won't go through all of these tests because I imagine that the tests that you use in Thailand or in Ecuador or other places might be different. But his IQ scores came above 100, so above average. His memory performance on a number of tests, such as the recognition memory test by Elizabeth Warrington, showed that he was in 67th percentile. And on the story recall task, the Wechsler memory scale that I presented earlier, he scored at 80%. So this is what we see with the patient. So whereas patients like KJ, DB, or my patient Nicola would have a severe impairment half an hour after giving information to them, this patient shows no deficit like that. So this is where we started working with him. And for this, I decided to use a task that I developed while doing my postdoctoral fellowship with Antonio Damasio and Dan Trinell, because I was working with a patient with confabulation, and we wanted to look at what happened to his memory because he was coming up with some interesting and bizarre memories. And in this task, I'd created 5 pairs of stories, each about 200 to 250 words, which we read out to the patient participant, as well as them having a sheet of their own to read from that. And we tested the recall of the stories in 2 ways, only one of which I'm presenting, and that was free recall. The way I'd created each story was that there were 20 points that you could get for each of these stories. So for example, there's a story called Concert about someone trying to go to a pop concert, and there were 20 points that you could get for this story, just like in the logical memory scale. Now, what we had was 2 classes of stories. One class of stories, which was the first 2, we tested them at every interval that we visited the patient at. And the other pairs, other stories, we only recalled at one time point. And this diagram explains this better. So stories 1 and 2 were presented on the day of learning. And we tested the patients and the controls recall at 30 minutes, 1 day, 1 week, 2 weeks, and 4 weeks. So we chose these because we knew that he was looking completely okay at 30 minutes, and his wife had said that he tended to forget things within 4 weeks. And every other pair of stories were only recalled at one time point. So these were the unrepeated recalled stories. So stories 3 and 4 were presented to him, but we didn't mention them again for another day, and then never again. Stories 7 and 8, for example, we taught him the stories on the presentation day, but we didn't ask for them to be recalled for 2 weeks. Now, this means that we could compare the impact of repeatedly recalling a story, which is stories 1 and 2, against those that are only ever asked to be recalled at one time point. And this is the data that we got for the repeated recalled stories. What we see here is that even 4 weeks later, the patient who's in red, he's scoring higher than the controlled or within a standard deviation of the controlled at all time points. So it looked like there was nothing going on here, since he could still recall the stories 4 weeks later. But when we look at his recall of non-repeatedly recalled stories, so those stories that he was only allowed to recall at one unique time point, in the healthy controls, we see that blue forgetting curve, which is the standard Ebbinghaus forgetting that we expect, and which is healthy because it's important to forget slowly over time. But with the patient, what we see is much more catastrophic forgetting. He's forgetting much more quickly than the controls. At the 30-minute time point, there's no problems. But a day later, a week later, 2 weeks later, he's completely amnesic, and he actually said that we were trying to trick him because he said, I've never heard those stories before. And so just to compare those, in the full lines at the top, we've got the patient and the controls, and we see very little forgetting there. Whereas in the dashed lines, we see that the patient and the controls with the stories that were only recalled at one time point. And what we see is forgetting, but for the patient, it's much more catastrophic than with the controls. So what we then did, so here for a start, we showed that there's a big impact of repeatedly recalling information. It seems to confer some sort of advantage to consolidating a memory. We next looked at how much forgetting was happening within each of those intervals. And that's what we see here, where we looked at the forgetting between the 30-minute and 1 day interval, between the 1 day and 1 week interval, etc. And what we see is that the patient's forgetting or loss of information was much higher for that first period from 30 minutes to a day than any other time point. So what this suggested was that although he was amnesic by 2 weeks, in fact, most of his forgetting happened in that first day. So a summary of this first study is that we've documented a patient with this accelerated long-term forgetting. And since the patient didn't have any diagnosis of epilepsy, the memory impairment that we were seeing couldn't be put down to the effects of anti-epileptic drugs. Now, this is quite important because this is the first case in the literature of a patient showing up without the possible confound of drug medication having caused the problem, because every other patient that's been documented had been taking anti-epileptic medication. The study also highlighted the importance of repeated recall as a protective factor, which we know from cognitive psychology is important, but here we're seeing a very stark impact of it. So that took us to study 2, because theoretically, it was useful to see that this patient who complained of memory problems subjectively can demonstrate a significant forgetting in memory paradigms. So from a theoretical perspective, it was an interesting finding. But given that forgetting is usually only obvious after 1 day of learning, clinically it is of limited use. Because in most countries, certainly in the UK, if a patient sees a clinician, they're likely to see them for an hour or 2 hours at most, and then they won't see them again, certainly not the day after. So the fact that we could detect the patient's problem 1 day later was useful experimentally, but not really useful for a clinician to be able to use, because the clinician doesn't see the patient the day after. So the aims of experiment 2 were to develop a test that could capture the patient's memory problem within an hour. And we created this paradigm called VAL-MT, which I'll walk you through in a moment, which is a learning paradigm where participants have to learn to associate 2